Thank you. Thanks for the opportunity, and I hope we've saved best for the last. I don't know how many of you, I'm sure a lot of you are awake and interested, and I know Nick is on the spot, so he's certainly going to be looking out for my slides. Um, okay, so it's a case presentation. The history is up on the slide. 30-year-old male, posterior urethral valves with previous metrophen of bladder augmentation, had a transplant in the pediatric age group, 1997, failed in 2012. IFTA, progressive graft decline. He also had PTLD before his graft failed, actually. He had PTLD, which was treated successfully, and he was in remission. Underwent a transplant nephrectomy due to graft intolerance syndrome in 2014, has a history of hypertension, and has a blood group, is blood group O. So this is his antibody profile. Samples in 2013 showed 5% CRF with some DP antibodies. In May 2014, patient had developed class 1 antibodies with 42% CRF. And Nick's not going to like that because this is when he underwent the nephrectomy. And in 2015, after he underwent the nephrectomy, we obviously had to give him a period of time off to recover, etc. And then we relisted him on the disease donor wait list in 2015. And he had a few blood transfusions between 2015 and 2016. And when we checked his antibody profile again, it was his CRF was 100% by 2016. So in 2019, his mom then came forward as a potential live donor. She was quite interested in donating. So she came forward as a potential live donor. And we typed her HLA, we checked for donor-specific antibodies, and up there on the screen are the donor-specific antibodies. So we've got an A23, we've got a CW4, and a DP antibody as well. The cumulative MFI was 32,000. Okay, so we at that time, although it was a CW antibody, but we thought given it's a high level antibody, we thought it's probably not wise to go directed, and we decided to enlist the patient onto the KPD, or the kidney pair exchange. We call it the UK Living Kidney Sharing Scheme. It's a long name, but it's a pair donation scheme. So the KPD, and these are the current positives. He was lucky that he had another donor, which was his friend. So the mom, by the way, there was a 25-year mismatch in age. So the recipient was 30, the mom was 25 years older, but his friend also came forward at the same time, and his friend was a similar age. So we worked him up as well, but he had quite a lot of antibodies, as you can see on the slide. So A29, A31B44, and some historic antibodies as well. So what are the options at this stage? What would people do?
Shafi, you haven't shown us the HLA type of the first donor. Do we know if these are repeat mismatches or?
Good question. So the first one, the A23, was a repeat mismatch. Yeah.
And the C?
It wasn't. No.
No.
It's just the A23.
So I think what I would do is perform a cellular cross-match with both of these, against both of these donors.
Okay.
Which I'm sure you did.
Yes.
CDC.
Well, they will do both, flow and
CDC. Flow and cellular cross-match. So same, it would go. I would do with mother a cellular cross-match.
Right, okay.
No, I think it is very important to know the HLA typing of the earlier donor. You're showing that the patient had antibodies to CW4.
Yes.
CW4 is in link with the disequilibrium with B35 in most populations around the world, including in India. If it is if it's an individual of Indian origin, we know the allelic
Yes.
distribution in various populations and all that. And I would do CDC. I would also do flow.
Yep.
If the CDC is positive but flow is negative, I'll go ahead with the transplant.
Right. Okay. So we stopped doing CDC. We do flow. So flow was positive, and the A29 was a repeat mismatch. So, I mean, I didn't put up the first donor's HLA type, but the A23 was or 29 was a repeat mismatch. So the way I see it at this stage is either we continue to wait on the disease donor wait list, hope that, he would be offered a low immunological risk transplant. Bear in mind, he's 30, right? So we want to give him a good quality organ. Or we go ahead with a high immunological risk, directed live donor transplant from the mother, desensitization of some sort, so that's an option. Or we go with a high immunological risk disease donor transplant if it does happen, if he's offered one. Or continue on the paid exchange scheme. As I said, 2019, we did enroll the mother into the kidney paid exchange scheme, so we can just keep enrolling them. So we do quarterly runs, so we can just keep rolling them every quarter. Or we could consider delisting some antigens. So that's another option. So what did we do at the center? So the MDT, we decided actually to delist in the kidney paid exchange scheme. So instead of just delisting antigens and leaving them onto the disease donor waitlist, waiting for a slightly higher immunological risk disease donor transplant, we've got a live donor here. But instead of accepting a fully compatible, HLA compatible live donor transplant, we said, look, you know what? We will delist onto the kidney paid exchange scheme. So we will trade the live donor, which is a high immunological risk, to another live donor, which is a slightly, perhaps an intermediate immunological risk. So that's what we thought we would do. So we decided to do some delisting, but enroll onto the kidney paid exchange scheme where we can have the possibility of delisting some of the antigens. So that's what we did. We delisted some of the antigens in the kidney paid exchange scheme in January 2023 to enable a HLA incompatible transplant, but a sort of in the spectrum, a risk that we thought we can actually manage. And our strategy compared to leads is to delist all current negatives. That's the first step. What we generally do, delist all the current negatives. Then the next step is to do HLA class 1 antibodies under 5,000, and that's what we did here. So, and even the class 2, I know they do 8,000, but we stick to 5,000 in our center for both class 1 and class 2. So that actually brought the CRF down to 98%. So, lucky for him, 18 months later, he got offered a live donor transplant in the kidney paid exchange scheme, okay? But you don't have to accept it, okay? We delisted some antigens, we put them into the run, and then we got an offer. We got a phone call saying, or email saying, we've got a potential offer. So this is what it is. So 18 months down the line, so we've got a HLA A29. Both I've listed the historic peak antibody levels, MFI, and the current. So the A29 is 4114. The B44 is 2120, and then the rest are negative, although they were historic positive antibodies. So next question. And before we go to the next question, this is the flow cross match values. We use RMF rather than actually median channel shift, slightly different, but yes, we have a cutoff of 4 before someone asked me. So our cutoff is 4. So the T cell was positive 5.26, B not so, yeah. So T cell positive flow. So what do you think we should do? Accept, not accept? Bear in mind, this is 18 months. He might be lucky another 6 months. He might be offered a slightly better one. What do you think? Yeah, after delisting. After delisting. Okay.
Well, so
Fine.
so
Before
imlifidase,
you come to
imlifidase would not be available for this in the UK. So there are very strict criteria for using imlifidase, and it's not licensed for living donor transplantation.
we decided to accept. But then brings the question, what do we actually do? We've got loads of drugs, daratumab, I don't know, you name it, right? There's loads of drugs. So what do we actually do? Which one do we use? And imlifid. You would accept it? Excellent. Perfect. Great. Yeah, we decided to accept it. Yes, so desensitization, that's the big question now.
What would you do next?
Yeah.
We were distracted.
We've accepted it. Great. Fantastic. So
Yeah.
what do we do next? We
I,
want to
you
make this
know,
work.
I would probably just perform the transplant without any preparation. And,
Okay.
however,
It's there.
he did show you. Yeah,
Yeah.
yeah.
Yeah. T
So I would probably just perform this transplant without any pre-transplant treatment, but you do have the opportunity, because it's a living donor transplant, if you wanted, you could do a bit of plasma exchange. So that would be perfectly reasonable to do. And I don't think I would be too worried about the history of lymphoma. I don't suppose you know if he's now EBV positive.
He's IgG positive.
Okay,
luckily.
well, that's
Yeah.
good. So I would definitely use a depleting antibody induction.
So I would like to offer plasmapheresis, because plasmapheresis doesn't only it clears the antibodies, it takes the complement system down too. So that way, offering a few doses of plasmapheresis as desensitization practice would help me a lot. Considering the EBV positivity and the past history of PTLD, I am little dwindle about use of
TCell.
ruxolitinib. Yeah,
Okay.
yeah, yeah.
Well,
But
anything
at
else?
least I would give
Right, thank
plasmapheresis
you. What
and
about
IVIG.
IVIG as well? Okay. What about other drugs? Retux? You, okay.
You are going to use a depleting agent. Okay, one depleting agent is required. In India, we do not get alemtuzumab so easily. We would have used thymoglobulin. And then I'm not sure, but I would have wanted the rebound to not happen because I am more worried about a rebound of the antibodies and a memory response coming. So, what would be the thoughts of using rituximab at day 15, 16 down the line so that you do not get antibody
No,
rebound?
here the T cell cross match on flow is positive,
Yeah.
but the B cell cross match is negative,
Yes.
right? So I think
Both were positive.
desensitization with
Ah.
3 rounds of PPIVIG would desensitize this individual. Again, do the cross match, the flow cross match. I'm sure, I
Sure.
feel it will become negative
Taking the time.
and go ahead for the transplant.
Thank
The
you.
problem is the rebound because
Okay.
you're going to get a memory. You have depleted them from the current circulation, but after a few days, like
Yeah,
after
but
imlifidase, you
Shruti,
get a
long,
So
rebound.
we'll come to the
rebound
rituximab.
comes from long-lived plasma cells.
So we'll come
And
to the
that you are
rituximab
not
in a
doing a
second.
test over there.
So
You only want to see whether
Let's just
antibodies have
let
gone down
Dr.
and therefore
Malik
you.
carry on.
thank you so much. So we'll come to the rituximab in a second, and I'll try and answer your question very, very, very easily. So what we did, plasma exchange and IVIG, like majority of the panel have decided and agreed on. So we did plasma exchange and IVIG. So we had the transplant was scheduled for the 29th. We had planned to stop one day before just for all the bleeding issues and things. So this is what we did. So we did in total we did about four exchanges. So after the third one, the antibody level had actually gone up the 829. So we decided to do another one, and then we did decide. So what we did on the day of the transplant, we gave some cryoprecipitate just to minimize any bleeding risk. So we gave some cryoprecipitate. And we also wanted to make sure the flow was negative, because we know from data that if the flow is negative on the day of the transplant, the outcomes are better. So we are lucky the flow was negative, and we went ahead. We also gave 1 gram of IVIG. So there's arguments whether you want to give 2 or not. I generally like to give 1 gram because I like to reserve another gram for AMR. So we gave 1 gram of IVIG at the end of plasma exchange. So this one, very quickly, if you look at the bottom, Stan Jordan, plasma exchange IVIG versus plasma exchange IVIG and rituximab, no difference in rejection rate. It really doesn't do anything. It doesn't deplete the memory cells. So, I wouldn't give rituximab. We didn't give rituximab. Immunosuppression, yes, Campath, TAC, MMF, and PRED. So 1 dose of Campath on day 0. And we watched every day. So the antibodies, we kept watching the antibodies, and they came back with a vengeance. On the day of the transplant, although it became negative, the 829, it went up to 2,600 on the day of the transplant, and then it went all the way to 20,000. So we had 4 antibodies to deal with: 829, 31, B44, DR7, all of them at 20,000 MFI. But we were monitoring it every day, and we started plasma exchange very quickly. He didn't want a biopsy, by the way, so which is why I've written no BPAR. So we didn't biopsy him. And he came on a Friday. He went home, by the way. Day 4, we sent him home. He was a live donor. Went home, came back to clinic. Creatinine started going up. Admitted, antibodies were going up. We started plasma exchange preemptively. So we did six sessions of plasma exchange. Antibodies came down, except one of them. All the other antibodies were down. And this is what happened. His creatinine. Yes, 1 gram. Exactly, 1 gram of IVIG. So you can see the creatinine, the GFR, his creatinine is now 115 essentially. So, he's got excellent graft function. So what we are left with, latest antibody monitoring, just one antibody, 2,400 MFI. His creatinine is 115. He's got excellent quality of life. He's on triple immunosuppression. He had BK, so we cut his MMF down a bit, but BK is gone. Other than that, he's actually done well. Few other things. So vaccination, we actually thought about eculizumab in case he had refractory rejection. So we did give some vaccinations just in case. And the black line is all the diseased people waiting. So in summary, people, the highly sensitized wait for compatible transplant. If no live donor, consider delisting followed by desensitization. But if you have a live donor, enroll onto the KPD or consider delisting within the KPD. And both policies are not mutually exclusive. They can be combined together innovatively to facilitate transplants. Thank you so much.